Hello, everyone, and welcome. Thank you so much for joining us. We're very excited to have you here. My name is Lauren Balascura, the Scientific Marketing Associate here at Norgen Biotech, and I'll be guiding you through today's webinar agenda. Let us know in the chat where you're tuning in from. It's always great to see how global this community is. And if you're joining us for the first time, a special welcome to you. Liquid biopsy is a rapidly expanding area of research and clinical practice, driven by its potential to reshape how we detect, monitor, and manage cancer. In today's session, we'll explore how this technology is influencing the future of oncology and improving outcomes for patients. We'll begin with a quick introduction to our speakers. Today's presentation will be led by Maggie Xue, Project Manager at Norgen Biotech. Maggie brings a strong academic background in biological sciences from the University of Guelph and supports our scientific teams here at Norgen. The Q&A session will be held by Dr. Lohit Khera, Head of Scientific Sales at Norgen Biotech. With over a decade of experience in cancer research and molecular biology, Dr. Khera developed his expertise at leading institutions such as the Weizmann Institute of Science and LSU Health Sciences Center. He's now focused on advancing global cancer research and diagnostics along the team at Norgen. Today's webinar will begin with an overview of liquid biopsy and cell-free DNA, with a particular focus on liquid biopsy itself. From there, we'll compare it to traditional tissue biopsy to better understand the evolving role of liquid biopsy in cancer care. To illustrate this concept, we'll use prostate cancer as a case study, walking through the clinical workflow and highlighting where cfDNA can be applied at each stage. We'll conclude the session with a Q&A, so please feel free to note any questions along the way, and we will answer them then. With that, I will now hand it over to Maggie.
Hi everyone, I'm Maggie, and it is a great pleasure to take you through our topic today. So I'm checking the chat now. I see you come from Netherlands, Canada, Egypt, US, and Mexico. We really get people join from all over the world, and what an amazing mix. Hello from Canada, and thank you for making time for us today. So I will start the presentation by diving into a little bit on liquid biopsy. Liquid biopsy is a simple collection method used to gather biomarker from bodily fluid for clinical purpose, such as detecting and monitoring disease like cancer. It can be minimally to non-invasive, with sample types include blood, urine, and saliva. And take blood as an example. So when cell dies through apoptosis or necrosis, they release fragmented DNA into the blood, and this is known as cell-free DNA or cfDNA. And if the DNA comes from tumor cell, it is called circulating tumor DNA or ctDNA. So in a blood sample, you can find cfDNA, ctDNA, and other cellular content like red blood cell, white blood cell, and even shredded tumor cells. And among all the analytes you can find in blood, cfDNA and ctDNA are the focus of today's presentation. And with a non-coagulated blood sample, these can be found in the plasma session. And I'm going to take a quick pause here. So for everyone who's watching, feel free to give us a thumbs up in the chat if the concept of cfDNA is new to you. Or if you have worked with cfDNA before, you are feel free to share your experience in the chat. And now let's keep going. So we all know that the one key benefit of liquid biopsy is that it is minimally to non-invasive. But why is that significant? Well, we need to compare liquid biopsy to the traditional tissue biopsy method such as surgery, endoscopic biopsy, needle aspirate, and etc. these tissue biopsies are invasive and come with a range of risks such as bleeding and infection. But do you know that in some situations, it even leads to cancer promotion? Well, we're gonna now look at this publication that highlight how needle biopsy can accelerate pro-metastatic change and systemic dissemination in breast cancer. Without a timely surgery after biopsy, there's increasing activity like epithelial to mesenchymal transition, where it makes the cell more mobile instead of stay localized. And the biopsy can also promote angiogenesis, the process of forming new blood vessels that supply oxygen and nutrient to tumor. And this eventually leads to systemic dissemination, meaning that cancer cells break away from primary tumor, enter the bloodstream, and travel to distant organ. And as this publication concludes, needle biopsy provoke progressive pro-metastatic change. That's really shocking, right? And I'm now looking at the chat. I see a lot of thumbs up. Well, welcome to the world of cfDNA. It is fascinating, and we are just get started. So another tissue biopsy challenge I want to mention is that it's difficult to sample hard-to-reach tumor. And I'm not even mentioning repetitive sampling right now. So you can take the lung cancer as an example. This picture right here shows how inaccessible the tumor location is for tissue biopsy. And in the same paper, it also mentioned how liquid biopsy enables sequential sampling for real-time monitoring. And the last point I want to highlight here is that tissue biopsy may miss tumor heterogeneity, especially when cancer has metastasized to multiple sites. The traditional biopsy only provides information on the predominant cell in the sample tumor. And if cancer has already spread it, like illustrated in the picture here, sampling from a single site may not reflect the full range of genetic mutation present in different metastatic locations. And for a more comprehensive genomic insight, liquid biopsy can review data from all tumor sites. And this study also echoed the same finding that liquid biopsy it can enable a more real-time disease monitoring. So, from the three limited examples we have shown today, we see that the value of liquid biopsy lies in its minimal invasiveness, its ability to support repetitive sampling, and the capability to provide broad genomic insight. However, and we know, liquid biopsy can do even more than that. So make sure you stay with us until the end of the session because we prepare additional resources and insight that will help you explore the full potential of liquid biopsy. And the future of liquid biopsy is promising. Between 2020 to 2030, the market was projected to grow by 16%. You can type yes in the chat if you already start to experience how cfDNA is gaining traction in your own work. And I'm checking the chat right now. I can see there already have a question coming in. We will answer all of that after the webinar. Okay, so you see, over the past decade, as you might already experience, the clinical use has expanded significantly, along with the number of validated applications and commercial tests. But keep in mind that the goal of today's presentation isn't to downplay the role of tissue biopsy. It is still crucial to understand the tumor structure, and instead, what I hope to highlight today is that the liquid biopsy has worked alongside it, help building a more complete and patient-friendly approach to cancer care. And I'm seeing the chat right now. I see a lot of yes that are coming in, and I always really love to see it. It really shows that the cfDNA is a game changer, isn't it? So, with all that being said, there's still one current liquid biopsy limitation, and that is sensitivity. So, take cfDNA and the ctDNA as an example. When cfDNA is scarce, like in the early stage disease, detecting ctDNA becomes even harder. So, for reference, cfDNA's level in healthy individual typically range from 1 to 10 nanograms per milliliter of blood. Well, the level are often higher in cancer patients. The circulation tumor DNA, ctDNA, represent only a tiny fraction of the total cell-free DNA in blood, and sometimes that can even be less than 0.1%. So this low abundance means that a negative result, it doesn't always rule out mutation. The ctDNA may just simply be too low to be detectable. And as the clinical guideline recommend, a confirmatory tissue biopsy is needed to ensure accuracy. And that's why at this stage, liquid biopsy serve as a complementary tool. Well, we know that cfDNA and ctDNA, they are already so limited. That means capture every fragment is critical, and effective extraction can boost the detection, and that's where Norgen come into the play. So, do you know that Norgen has collaborated with oncology researcher for over 25 years? Yeah, we have 2.5 decades of solving liquid biopsy problem before it become a good thing. Well, I promise you I won't do a product pitch today, but I do want to show you one thing. Okay, let's do a quick unbox here, and you can see that this is where all the magic happened. Let me take out one piece to show you, and let's look at this beautiful reverse Oreo looking piece right here. Hint, this is not a cookie. And it's definitely not your average silicon raisin. This is Norgen's patented silicon carbide technology engineered for maximum binding power, especially for those ultra low concentration, small sized cfDNA fragments from blood, urine, or saliva, and etc. And seriously, this thing works harder than a grad student at midnight before a conference. And from this publication evaluating commercial cfDNA purification kit, Norgen demonstrates not only the highest overall cfDNA coverage, but also superior recovery of DNA fragment less than 150 base pair. This level of performance is crucial in oncology, and that reflect our commitment to help researchers around the world. So you can let us know in the chat if you've used any of our kit, and we always love to hear experience from you. And well, I won't turn into this whole show into a product showcase unless you really want me to do so. But just remember that our ongoing commitment is reflected in the growing body of researchers supported by our products. And if you're curious to dive deeper, feel free to message us. We will connect you with a real human scientist, not a chatbot, and I pinky promise you. Okay, so let's get back to the main topic. You see, across oncology, the common challenge arises regardless of cancer type. And to explore how liquid biopsy addresses this, we will use prostate cancer as a case study today. And I chose prostate cancer today because it is highly prevalent. You see, 1 in 8 men will be diagnosed during their lifetime, and it is the second leading cause of cancer-related deaths in men. And what's more important is its a biological characteristic which highlight how cfDNA can contribute. So one key feature I want to highlight is its heterogeneous nature. Prostate cancer behaves differently across patients. In some cases, it progresses slowly and may never be life-threatening, while in other cases, it is aggressive and lethal. This variability underscored the need for improved risk stratification, diagnosis, and prognosis, and those are the areas where cfDNA and ctDNA can play a very crucial role. On top of that, prostate cancer often spread to the bone, which is a difficult site for tissue biopsy like we mentioned before. And that is another reason why minimally invasive options like liquid biopsy are valuable. So Before we dive into the specific role of cfDNA in prostate cancer care, I do want to take a short 5 minutes to walk you through the standard clinical workflow. This will help you understand where cfDNA fits and how it contributes. I will start from screening to diagnosis, prognosis, treatment selection, and to response assessment, which often rely on similar technology as the ones used in prognosis. Well, some of these approaches are specific to prostate cancer. Many are also applicable across other some cancer type as well. And let's start with screening. The most common entry point is the PSA prostate-specific antigen test. It is a protein biomarker made by both normal and cancerous prostate cell. The elevated PSA level can signal cancer, but it also may arise from non-cancerous issue like a prostatitis or enlarged prostate, which could lead to false positive. Well, with that being said, it is still the most often used screening tool to recommend for the men that are over 50 with risk factors or symptoms. A DRE digital rectal exam also often accompany it to check for physical abnormality. And if the results are concerning, a tissue biopsy is performed for microscopic analysis, and the goal is to confirm if the cancer exists. Well, the multiparametric MRI is increasingly used before biopsy these days to improve biopsy accuracy and reduce unnecessary biopsy. And although this concept is not related to cfDNA, it does share the same goal to make cancer care more precise and less invasive, and therefore reducing patients' burden. So once cancer is diagnosed, we now shift our focus to understand its behavior. One metric to do that is the Gleason score. It is specifically to prostate cancer. A grade prostate cancer based on the cell appearance and the architectural pattern. While it's specifically tailored to prostate cancer, the TNM staging system is used more broadly across oncology. The TNM system provides a consistent framework for understanding how far the cancer has progressed, where T stands for tumor size, N stands for lymph node involvement, and M stands for metastasis. This helps us understand whether cancer is still localized or it has been metastasized. And along the way, the PSA level continue to be tracked here as a measure of disease progression. And in recent years, there are several new methods has begun to supplement the traditional ones. One of them is a PSMA PET imaging. It really enables the visualization of a metastasis, help identify small or otherwise undetectable lesion earlier. And the genetic testing is also gaining traction here. It can be done through ctDNA analysis to identify mutation in AR or HRD gene. If those terms hasn't sounded familiar to you yet, well, don't worry. We will get into greater detail very shortly. And finally, so after all the effort in prognosis, in this section, we'll start to look at some key treatment options across different stages of prostate cancer. So for men with low risk, localized prostate cancer, active surveillance is often recommended. This means just to monitor the disease without immediate intervention. And as the risk increase to intermediate or high level, or if it has spread to neighbor tissue, surgery like a radical prostatectomy coming to remove the entire prostate gland and some surrounding tissue. And at this point, the goal is to remove all detectable cancer and reduce reoccurrence risk. And for non-surgical candidates and others, radiotherapy is used to kill cancer cells or prevent growing and when the disease becomes even more advanced. Systemic therapy enters the picture, and these are the treatments that travel through the bloodstream to affect cancer cells throughout the body. So now let's take a closer look at this systemic treatment. I want to spend a little bit more time here because it will help us understand how cfDNA can become relevant later. And let's start with a little background information. So prostate cancer cell rely on androgens like testosterone and DHT to survive. So androgen deprivation therapy (ADT) it attempts to slow or stop cancer growth by lowering the androgen level, either through medication like indicated in the box here, or by surgically remove the testicle. And while ADT reduce the androgen level, some cancer cell it can still survive just by using a little remaining hormone. So that's why we're bringing androgen receptor inhibitor. These are the drugs that block the receptor from receiving the androgen signal. And however, as patients receive ADT and AR inhibitor, the tumor itself starts to adapt and survive. So this eventually leads to aberrations such as AR gene amplification, mutation, splice variants, and those eventually drive resistance to therapy. And that is when chemotherapy come into the picture, especially after ADT and AR inhibitors stop working effectively. Well, the goal right now is no longer about to cure the cancer, but chemotherapy can slow the progression, and this is done through targeting microtubule, an essential part for cell division. And there's another option called a PARP inhibitor, which is a type of targeted therapy. And to fully understand how it works, we need to look at some background information on DNA repair. And I think most of you already know that DNA can be damaged basically from a lot of reasons, radiation, chemistry, or just metabolic process. And for a single strand break, a protein called PARP can help fix it. But for double strand break, they are repaired through two pathways, and the BRCA1 and BRCA2 are the example of a DNA repair protein involved in one of the pathway called HRR pathway. They are produced by their corresponding tumor suppressor gene BRCA1 and BRCA2. So when those genes are mutated, the repair system just fail, and that is called homologous recombination deficiency, or HRD. Knowing this genetic information through tissue or liquid biopsy is important for prognosis reason because we all know that DNA damage often leads to mutation which result in cancer. So people with HRD gene are at higher risk to developing cancer, including prostate cancer. But on the flip side of the coin, from a precision treatment perspective, the patient with HRD are prime candidate for the PARP inhibitor therapy. And the logic is that since the double-strand break repair system doesn't work, the cancer cell must rely on PARP to repair the damage, and the PARP inhibitor adds future stress, and eventually it will push the cancer cell towards death. So that's an overview on the prostate cancer care workflow, and I know it must be a lot if it's your first time learning about cfDNA or prostate cancer, and you can give yourself a big thumbs up for following along so far, and if not, don't worry. By the end of this presentation, you will receive the recording along with other additional information to help you understand, and again, we will have another scientist help you answer questions. And now let's start moving to the exciting part, which is the involvement of liquid biopsy and the ctDNA. So one important point to note before we continue here is that the ctDNA level rise in parallel with tumor volume, which increase as cancer progress and especially into metastatic stage. Therefore, the ctDNA has a greater utility as a biomarker in advanced stage because it has a greater fraction, and as we mentioned before, when cancer metastasizes to multiple sites, liquid biopsy can offer a more comprehensive genomic profile. But given that ctDNA has limited application in screening and diagnosis, This stage requires higher sensitivity to detect the small tumor volume where ctDNA is less abundant. And the study thus shows that ctDNA concentration in patients with localized prostate cancer are often low and even similar to those in healthy individuals. And why I do find one interesting study for you, which found out that the detection of ctDNA in patients with localized prostate cancer was linked to rapid disease progression and shorter metastasis-free survival. However, the study relied heavily on whole genome sequencing and deep targeted sequencing on a small cohort. And the complexity and the cost of this technology really just make large-scale implementation unlikely. But with that being said, while ctDNA has limited application in screening and diagnosis, its value really shine in prognosis and treatment selection. And then now let's look at two specific examples that shows how cfDNA can match or even outperform tissue biopsy for genomic analysis. Okay, so we can start with a quick recap to make sure everyone feels manageable before we move forward. The antigen receptor aberration are developed from treatment like ADT and AR inhibitor. The detection of AR aberration indicates that the AR targeted therapy is resisted and it means it's no longer effective. Therefore, a switch to other therapy like chemotherapy is needed. And the homologous recombination deficiency referred to an impaired ability to repair DNA double-strand break, which often caused by mutation in genes such as BRCA1 and BRCA2. The detection of HRD gene suggests that a patient may be eligible for treatment with a PARP inhibitor. And you can see that in both situations, the genomic analysis play a key role in guiding the treatment decision, allowing for more tailored and a precision approach based on each patient's unique genetic profile. And this not only improves the treatment efficiency, but also help minimize unnecessary side effects. But here comes the question. How is cfDNA from liquid biopsy compared to tissue biopsy? And we can do a quick poll here. So, if you have to pick one, cfDNA or tissue biopsy, which do you think that will give a better insight for treatment selection? You can type cfDNA or tissue in the chat, and we're curious to see the split. So, before we dive in, I will wait 5, 4, 3. You can lock your answer. 2 and 1. Before I dive into my finding. And here, you see this publication, it analyzed the genomic data from over 3,000 patients comparing liquid biopsy cfDNA with traditional tissue biopsy in terms of AR resistance. In this study, the orange column represents mutation found only in tissue. The blue represent those found in both tissue and liquid biopsy, and the green highlight the mutation detected only through liquid biopsy. Well, you can see a decent portion of results were concordant, but notably, ctDNA from liquid biopsy reveal additional AR mutation that's not detected in tissue sample. This unique finding were identified in the publication as AR-resistant alteration, emphasizing the value of liquid biopsy in uncovering clinically relevant mutation that might be missed using tissue alone. And another article I want to highlight here investigated the detection of HRD-related genes such as BRCA1, BRCA2, and ATM using both ctDNA and tissue biopsy to identify if a patient are eligible for PARP inhibitor therapy. And as you can see, which is highlighted in red here, the study found the strong concordance between the two, with 81% agreement in mutation detected by both, and 92% in case where neither detect mutation. And when we really dive into the OncoPrint that summarizes the genomic alteration in BRCA2, ATM, and BRCA1 from both tumor tissue and ctDNA, we also observe a high level of concordance, and this suggests that ctDNA testing it can effectively complement traditional tissue testing when determining eligibility for PARP inhibitor therapy. And after look at this two specific example that shows how ctDNA is reliably able to guiding the treatment selection, I hope by now you are having a better understanding on cfDNA and ctDNA's full potential. And now let's take a step back and look at the broader role of ctDNA in prognosis. So here I want to present you with a literature review that bring together several cfDNA study centered on metastasized prostate cancer. So it shows that ctDNA detection level in metastatic castration-resistant prostate cancer range from 43% to 82%, depending on the treatment each population is undergo or the technique used. And ctDNA can reveal aberration-driven resistance to the treatment, such as ADT and AR inhibitor, where we mentioned before. This information can then be used to guide the selection of alternative treatment strategy that are more effective for patients. It can also be used to predict therapy outcome, which not only help clinicians select the most optimal treatment, but it also provides a more real-time view when adjustments are needed. And finally, study has shown that the ctDNA it can serve as a complementary tool in multivariate analysis. It can also be used as a standalone prognosis marker, and it is correlated with other clinical parameters such as PSA level, bone metastasis, and LDH. Well, this is significant because it really highlights that ctDNA's growing importance in accurately monitor disease and guiding personalized care. And that is a brief overview of ctDNA's role in prostate cancer care. And you can give us a thumbs up if you're catching up, and I'm giving you a thumbs up for sticking with me for this long. But just so you know, the exciting part is yet to come. So we now know that ctDNA, or more broadly cfDNA, is a promising tool. But what I've shown you today is the end result of a complex analysis process. And there are many pro-analytical factors that must be carefully managed to fully harness cfDNA's potential and to ensure the results are reliable and clinically useful. So, call out to all the scientists who are watching today. If you ever face challenge with sample quality in liquid biopsy workflow, you can type yes in the chat, or you can even tell us what went wrong. And without getting too technical today, I will only highlight just one key factor, which is the sample collection. So here is a publication that explores clinical opportunity and the challenges of liquid biopsy in prostate cancer. It mentioned that one major goal during collection is to avoid genomic DNA release from lysed leukocyte. Because ctDNA make up such a small portion, the genomic DNA contamination can dilute it and lead to false negative. Well, EDTA tube are commonly used. I believe if you are in the industry, you heard EDTA tube a lot and a lot. But the thing about them is they must be processed within 2 hours of collection. And to extend the preservation time, there are companies to make some blood collection tube with a fixative agent. Well, it is able to keep the cell intact for 7 days or more, which is better. However, this fixative can cause cross-linking and a chemical modification that interfere with downstream DNA application. Well, I have to say this already sounds like a better option comparably, but don't you feel there's just a lot to juggle with? You get to protect your cfDNA, avoid genomic DNA contamination, watch out for hemolysis, and don't even get me started on DNA cross-linking with those fixative field tube. It is really like, how many things can one person juggle? Well, that's why Norgen said, you know what? Let's take that stress and make it science-proof. Norgen offers a solution that makes this consideration even further by addressing all the above-mentioned challenges without introducing side effects. Norgen's blood collection tube can preserve cfDNA for up to 30 days at room temperature, along with other key cancer-related biomarkers like cfRNA and CTCs. No hemolysis, no cross-linking, no weird chemical residue that will make your QC chart look like a modern art piece. And you might be thinking, oh, that looks like a little too good to be true, but I'm telling you, it is not. Here is a peer review publication that compare us to the top performer in the market, and guess whose yield is the highest? Well, check out this publication and check out this abstract in highlight. And here is the hint. Well, it starts with an R and it ends with Jim. I think I hear my answer. And now I'm not going to go deep into every pre-analytical wing that Norgen is supporting in prostate cancer research. But let's just say if you need proof, and we do have them. So I won't go into any of the detail, but here is just an example list of a publication that Norgen has supported. And if you're thinking, I want more of that, we've got you covered. We have a blog that explores how other biomarkers beyond cfDNA from liquid biopsy source beyond blood can contribute to prostate cancer research. We also have a separate blog focused on exosomal mRNA as another rising biomarker for prostate cancer. And if you're a visual person, there's a whole workflow roadmap that shows how our solution plug in your research pipeline. And if you're attempting to try our stuff, here is your moment. Because we've got a promotion running until June 2nd, 2025. AKA, it is a great excuse to try something new and tell your PI and the boss, look, it is on sale. And if you're the boss, well, you deserve to treat yourself better because you deserve good cfDNA. And that brings us to the end of today's presentation part. Thank you so much for your attention. I will now hand it over to Dr. Lohit Khera for the Q&A session. And while I do that, here's a quick 2-minute break. You can take your time to do some stretching, review some coffee, and ask your question in the chat. I will see you soon. Hello, everyone. Welcome back. I hope you have a good stretch. You refill your coffee and you type your question in the chat. Well, I will start going over from the top. And the first question I have here is from Miles. Oh, by the way, this is Dr. Lohit Khera that has been joining with us today.
Thank you, Maggie. Thank you for the introduction, and also thank you for an amazing session today. The second one. So you're doing great, and it was very informative. Once again, I loved all the information and all the infographics that you used to make it really easy to digest. Thank you.
Thank you, Lohit. And now we can start jumping the question by Miles. So, hi, I'm a college student interested in cancer biology. Hi, Miles. We're really happy to have you here. And I always hear that the tumor cells are great at avoiding cell death. So, if they're not dying, where is ctDNA even come from? Oh, and there's a follow-up part. So, Lohit, be ready to address all the questions in one go. Also, Myler has asked, does ctDNA mostly reflect cells that are already vulnerable or dying? And if so, are we potentially missing the most aggressive part of a tumor when we're analyzing ctDNA? That is a good question.
These are really deep questions. Thank you so much, Miles. So the first part of the question is if the tumor cells are are good at evading death, right? And the ctDNA actually comes, or the cfDNA actually comes from dead cells. Then how come we have tumor DNA in form of cfDNA? Very good question. So the answer lies in the dynamics, right? For cfDNA, the biogenesis of cfDNA is that cells will die because of apoptosis, necrosis, different types of cell death, and they will release their DNA into the stream, into the bloodstream. And this DNA is most of the times fragmented, and these fragments are protected because of the DNA wrapping around the nucleosomes. And this is why you always have a certain length between 140 and 170 base pairs of DNA, because that is the length of DNA that wraps around each nucleosome, right? Now the same DNA can also come from tumor cells, because when a tumor is growing, in fact, I'm going to include a little bit of your second question as well. So when a tumor is growing, and if it's aggressive tumor, then actually it's growing so fast that it
Okay.
reaches some areas that do not get enough oxygen supply,
Okay.
and those cells might die off, right? So in fact, more aggressive tumors will release more ctDNA in the stream. In fact, it's opposite, that when we have some tumors that are very slow growing, or some tumors that do not have a lot of this dynamic, a lot of turnover, those are the tumors that actually are hard to catch, because they will release very little ctDNA in the stream.
Okay.
So that's how we still have tumor DNA that is accessible from the cfDNA fragment.
Okay, a lot of information is actually my first time hearing, and I hope that answered your question, Miles. So now let me go down the list, and Mia has us a question. Just wondering, are there any cfDNA assay that's already used in clinic for guiding treatment decision, like selecting PARP inhibitor, or is it still more on the research side? Lohit, what do you think?
Yes, so we are aware that there is at least one um, FDA approved assay that is being used, and that is in fact for particularly pancreatic cancer, the metastatic castration resistant pancreatic cancer, the MCRPC. For that, there is an assay that is provided by Foundation One, and
Okay.
that actually looks at BRCA mutations and other mutations to qualify patients for PARP inhibitors. So yes, there is at least one. But yes, there are a lot of other assays that are being developed, that are in research, preclinical research right now, and we don't know, but we expect that they should be hitting the market soon.
Yes, as we mentioned in the presentation, it is a fast-growing field, and a lot of people have a tripping effort, and we're looking forward to witness what's going next. So there is another question come from Marisa. From Marisa, hi, you've mentioned that the ctDNA level are low in localized prostate cancer. Are there any new technology or protocol emerging from that improve the sensitivity for early detection?
So yes, it is correct that ctDNA levels, we discussed this earlier, that cfDNA levels themselves are very low, and then ctDNA is a very small subset of the cfDNA population, right? So you have to have very sensitive methods to detect it. Now, one simple way is that if something is very low in amount, you increase it. How do you
Mm-hmm.
increase it? Okay, you don't start with 1 ml of plasma, but maybe start with 5 ml of plasma. So now you have a total of 5 times more cfDNA to work with.
Mm-hmm.
So that should kind of, you're not increasing the sensitivity, but you're
Okay.
making more of the cfDNA available for the assay. That's one way to go for it. That's the simplest one. But in other cases, there's also other things that you could do, that scientists are doing actively, which is, uh, if you don't know what you are looking for, then you need a lot of cfDNA and ctDNA. But if you can target, for example, if you know what is the tumor type that you are looking at, and what are some known mutations
Mm-hmm.
that you are looking for in these sequences, then you can do a targeted deep sequencing or deeper analysis. And in this case, smaller amounts of ctDNA are okay to use, because you know what is the particular sequence change or mutation that you're looking for. So that really helps.
Okay, that's also my first time hearing about it. Marisa, I hope that answered your question. The next one on the list is from Sarah. Sarah said, I've always used EDTA tube for cfDNA. And how are Norgine cfDNA preservative tube different in terms of performance? Well, you get to the right place because this is our cfDNA expert.
Yes, so that's a good question. Now, if you're asking in terms of performance, we should actually be saying that there shouldn't be a huge difference in performance, because if you're looking for collecting the plasma sample, you should get similar results from EDTA and from a cfDNA preservative tube like Norgine tube, right? So that level of performance is the same. But what is the main difference is the preservation itself, because EDTA tubes, they help you to separate the plasma, but you have to act fast. A plasma sample that is from EDTA tube has to be collected within a few hours, even if the sample is refrigerated. You have to be very fast. There's almost no preservation there. But with our preservation tubes, we ensure prevention of hemolysis. So
Mm-hmm.
we make sure that there is no genomic DNA coming in. And also the cfDNA and cfRNA that are present in the plasma sample, they are now preserved, which means the plasma sample can be separated from the entire blood sample up to 30 days.
Okay.
And this plasma sample can be stored, or the tubes can be stored for up to 30 days before separating the plasma sample, even at room temperature.
Mm-hmm.
And nothing will happen to cfDNA and cfRNA. So the preservation is what makes our tubes different.
Mm-hmm. Yeah, thank you, Lohit, for a very informative description. And although Lohit has said a lot, but I know sometimes a picture wins a thousand word. So at Nodger, we actually have a lot of graph and publication compared the EDTA tube and how Nodgen's tube perform. So Sarah, if you're interested, we will forward you with additional information after the webinar. And now let's get to Rosanna. What's your take on where ctDNA is heading in oncology? Do you see it becoming standard practice anytime soon, or is it still a few steps away from routine clinical use?
That's a good question. That's more like, a field question in terms of cancer biology. So that's really good. The real answer depends a lot on the current research, but we have to say that we are seeing more and more new assays coming out that are using cfDNA as the analyte, and that would mean that even the clinicians and the oncology researchers as a whole, they're all moving towards this direction. Because see how easy it will become if we were able to get all the insights from a liquid biopsy sample. It's not just about you know, detecting early or detecting the cancer. It's also about regular checkup, regular follow up of all these
Mm-hmm.
patients, right? You can't send the patient for a biopsy or a tissue biopsy every few months or every year, right? But if it's just about a blood sample and you will be able to get that insight, the follow up becomes very easy.
Mm-hmm.
And this is why the entire field is rigorously moving towards this direction of liquid biopsy. And I think if not a few steps, but maybe very few steps, maybe one or two steps away. But yes, we are getting there. And I think this is going to become a routine clinical practice very soon.
Mm-hmm. Yeah, thank you, Lohit, for a very insightful answer and really take us to a more holistic overview understanding of it. And next question I've seen here is from Rebecca. So, hi there. I've been using Norges Kit for actually 4 years now. Oh, we always love to hear that. And our team has loved the result. Oh, even better. Okay. So, any new product or improvement coming out soon that we should know about? Lohit, what do you
Mhm.
think?
Amazing. Yes. Thank you for that question. So as you know that although I am a part of the sales team and the tech support team, but I do work very closely with our R&D team as well. So we cannot reveal too much about
Mm-hmm.
it, but we have to say that because we do design and develop all our products in house. So we are working on some products that are going to make it easy to address more variety of questions. And as I just said that, right, if you want to work with more samples, because that's what the future looks like, right? If
Mm-hmm.
everyone is going in this direction of liquid biopsy, then clinicians will need to assess information from more and more samples at the same time. So one
Exactly.
thing is automation, right? So that is one direction that Norgen Biotech is also moving in, to provide kits that are more automation friendly. So more and more samples can be assessed together. So basically automation and high throughput at the same time. One challenge that lies in that is if you're going for high throughput and still maintaining the large volume of plasma input, that is a challenge that we need to address as you know, for the field. So yes, that these are certain things that definitely we are working on, and I hope very soon we will have these products out.
Mm-hmm. Yeah, yeah. Let's hope and keep a closer eye on Norgen's kit. And next question is by Josh. Josh has asked, does Norgen also have a product that can capture gene expression in liquid biopsy for prostate cancer? What do you think, Lohit?
Right. Yes, of course. So when you say gene expression, I'm going to assume that you're talking about now RNA. So DNA is something that contains all this information,
Mm-hmm.
right? So
Yeah.
that's the genetic material. But then RNA actually tells us that what are the genes that are being expressed at a given time. So when we're talking about gene expression, we are mostly talking about RNA. So that's correct, actually. So the same tubes that we just mentioned, the cfDNA preservation tubes, they are actually, the full name is cfDNA CFRNA preservation tubes. So this is a product that, of course, enables the capture and preservation of
Mm-hmm.
the sample. So that's one. And then just like we have cfDNA extraction tubes, we also have a lot of cfRNA extraction tubes from all types of liquid biopsy samples, including plasma, including urine, including even saliva samples, where we can separate the small RNA from large RNA. So we have all of these different types of kits that where we focus on gene expression. In fact, RNA is something that Norgen Biotech is an expert of. We have called the true RNA experts
Mm-hmm.
for that reason only. So yes, we have a lot of products for gene expression.
Yeah, thank you, Lohit, and I hope that solved your question, Josh. And as time is approaching, we do have a one last question. Catherine asked, are there technique being developed to improve sensitivity in low ctDNA samples?
Right. So this is very similar to a question that we recently answered. Yes, there are new techniques that are being developed to improve the sensitivity. And as we said, one way is that you can go around improving the sensitivity by just making sure that you have more of ctDNA,
Mm-hmm.
which is if you're starting from 1 ml of plasma, can you start from 5 ml of plasma? And then you have more cfDNA, which means you have more ctDNA to work with. And that way you don't have to improve the sensitivity, but you can simply go and have more of ctDNA available for this assay, for the assay that you're using. But in terms of other techniques, there is like it's called a tissue educated or genetic DNA educated techniques,
Mhm.
where you already know what are all the mutations that
Okay.
are present in the tissue, in the cancer tissue,
Mhm.
and then you know that these are the mutations that I'm looking for, right?
Mhm.
And then when you know that what you're looking for, then you can work with smaller amount of ctDNA as well, and you can
Okay.
just do an ultra deep analysis. So knowing already that what you're looking for, that can be very helpful in designing high sensitivity assays.
Okay. Yeah, a lot of information to unpack, Catherine. I hope you get your answer. And I didn't see much question coming in, and the time is also has come, so that marks the end of today's webinar. So for any question that won't address during the webinar, or if you have additional question after the presentation, well, we got you covered. So we will be send out a survey where you can submit your remaining question, and a knowledge scientist will be happy to assist you with them. We also have the QR code right on the top if you want to fill the survey right now. We will greatly appreciate if you can take just 2 minutes to complete the survey, because your feedback will help us create even better content for you next time. And keep in mind, I will be sharing the webinar and the additional resources I mentioned before after the session is over. So if you are interested in any specific topic, feel free to check it out. And I really enjoy walking you through today's session. Have a wonderful rest of your day. Thank you.